Good morning, everyone. I'm Dr. Tim Allen Williams, Chair of Medicine here at University of Louisville, and welcome to Internal Medicine Grand Rounds. We are so pleased this morning to have Dr. Dolores Shoback, who is a professor of medicine at UCSF, and she is actually the person who runs the training program at that institution and is a specialist in both diabetes and endocrinology. She'll be talking to us about diagnosis of and management of osteoporosis. But for the proper introduction, as we always do, I'm pleased to introduce Dr. Sri Gundam, who is our division chief in endocrinology. He is a professor in our university and he has been a stalwart leader in this area. I'll turn it over to do the proper introduction.
Thank you, Dr. Williams. Welcome, Dr. Shoback. We are very pleased to have Dr. Shoback back here at the university to present a talk on osteoporosis at the University of Louisville. She was here about in 2015, over the last 9 years, I'm sure there are more things that that we need to learn. Dr. Shoback is currently professor of medicine in residence at the University of California in San Francisco in the Division of Endocrinology and Metabolism. She graduated from University of Pennsylvania and went to medical school and residency at Johns Hopkins and did fellowship in endocrinology at Harvard Medical School at Brigham and Women's Hospital. She then moved all the way west to California and has been in San Francisco over the last 40 years, where she's currently, as I mentioned, professor of medicine. She's also been very active in the endocrinology fellowship training program, having been a program director and later on now continuing to serve as associate program director there. Dr. Shoback has been a stellar clinician and a clinician investigator who has been recognized for her scholarly work over the last few decades. She has won numerous awards and honors, including the Sidney Ingbar Award for Distinguished Service from the Endocrine Society, the Scholarly Physician Award from the Endocrine Society. We were very privileged to invite her here to deliver the Towery Lecture in 2015. She is an expert in the field of osteoporosis and has been on several guideline committees. And today she will be presenting to us an update on the management of postmenopausal osteoporosis. Dr. Shoback.
Thank you so very much for the invitation and also for that really very, very nice introduction. I really am pleased to be able to be here with you today, even though it's virtual. I have such wonderful memories of my trip to Louisville in 2015. And so I am thrilled that you invited me back to talk about one of my favorite topics, which is osteoporosis. So thank you for the invitation and thank you for coming to the talk. I have no disclosures to make with respect to this presentation. And so we'll get right into it. What I'd like to talk to you about this morning is certain topics within osteoporosis, which I think are current and important in our day-to-day management of patients. And the first of that is how we risk stratify our patients as we're thinking about offering different forms of therapy. So a fracture risk stratification algorithm, perhaps, if you will. Then we're going to spend some time on the recommendations for the management of osteoporosis that come from the American College of Physicians, a recent guideline on this topic. And that guideline involves several different approaches to therapy. And the ones I've bolded here are ones that we're going to spend a little bit of time talking about with a slant toward how these fit into the management of patients in internal medicine. And then finally talk just in the last few moments about vitamin D. There's a lot of information out there about vitamin D, some new trials, and some very recent guidelines that I think are worth knowing a little bit about. So that's what we'll do over the next 40 minutes or so. So when I approach a patient with low bone mass or with fractures or a very abnormal DEXA, I'm thinking about fracture risk over time in that particular individual. And I think there's two important concepts when we think about fracture risk in a patient to consider. And one of them I start with really is what I call the baseline risk. That's driven by the individual patient, his or her characteristics, the demographics, the DEXA scan results, the FRAX calculations that you do from the clinical risk factors and the bone mineral density. So that's one very, very important concept of risk that we take into account when we evaluate patients. But then I think it's becoming very, very clear that we need to take into account what the imminent or what is called in the field the near-term fracture risk that that particular patient has. And looking at a patient from both standpoints is pretty important as we're planning the management of that patient. And we went into that, and I had the privilege to participate in the development of these guidelines for the Endocrine Society. But they really start with that fracture risk assessment of the patient. And the sort of approach that we put together, I've summarized here on this slide. And it really starts with getting the DEXA, getting the bone mineral density, calculating the FRAX scores either, or use another tool, but to calculate 10-year or distant fracture risk. And then in this guideline, we define sort of 4 categories of risk, mainly focusing on postmenopausal women, where the largest population of patients at risk is, and certainly probably the most important. But the low-risk patient, so the low risk is someone without any fractures, with normal T-scores and with low FRAX scores. So that's easy. The moderate risk patient is one with no prior fractures. And so you see, very importantly, we're assessing fracture history from the start. That person has, or that woman has, T-scores above -2.5. So doesn't meet the threshold by DEXA for osteoporosis, and has FRAX scores that are better than those that one would consider in the United States. And that's the 10-year risk of a hip fracture of 3% or higher, or a major osteoporotic fracture of 20% or higher. But that person in the moderate risk category doesn't meet any of those criteria by FRAX for considering drug therapy. And it's these two sort of groups of patients, the high-risk patient and the very high-risk patient, that we are targeting for pharmacologic therapy based on the fracture risk assessment structure that guideline put out. So the high-risk patient is one with the prior spine or hip fracture, a T-score or a T-score below -2.5, so hits that threshold by DEXA, or has FRAX scores that again meet the threshold for considering therapy. So that's the high-risk patient. And then the very high-risk patient is one with multiple fractures. And here we said spine fractures, for example, and T-scores that are below -2.5. So a framework for you to think about sort of risk stratification of your patients as you're evaluating them in the clinic. Now, this imminent near-term fracture risk that I've already mentioned to you really refers to what's the risk over the next, say, 2 years in that patient that you're evaluating. And what are the data that this is critically important? Well, it comes from quite a bit of data in the literature, and I've just put 3 of the studies that really underscore how important imminent fracture risk is. So this is a study from 20 years ago where they looked at women who had an X-ray showing a vertebral fracture, and it was known to have happened in the prior year. So you had a prior X-ray, negative, and then you had another X-ray within a year that showed a vertebral fracture. That person has an absolute risk of having another fracture in the next year of 20%. And that's pretty striking as a risk factor. So a radiographic vertebral fracture marks that patient as high risk. This is a study looking at 50,000 women over the age of 55 with osteoporosis, okay? And if that woman has had a fracture or multiple fractures, even if it's a long way back in her history, she has a high near-term fracture risk. And for example, the 2-year incidence of fracture in this study, if there were no prior, was 5%, another osteoporotic fracture. If there was 1 fracture in her history, 10% over that 2 years. If 2, 16%. If 3, 25%. And so you can see that fractures, in a sense, beget fractures. The strongest data set really for this imminent near-term fracture risk concept comes from this large Medicare claims data set, almost 400,000 women over the age of 65 who had an incident fracture without any associated trauma. Within the next year, there was a 10% risk of any clinical fracture. In the next 2 years, there was an 18% risk of a recurrent clinical fracture. And over the next 5 years, a 31% increased risk of fracture in those patients identified by having had an incident fracture. And here's a little bit more of the data that they accumulated in that study. So this is showing us the cumulative risk of a new fracture within 2 years by age and by the site of that initial fracture. And I'll just call your attention over here to the patient who presents with a spine fracture. Over the next 2 years, essentially regardless of her age, she's got a 25% chance of having another osteoporotic fracture. So very high risk situation. If it's a hip fracture over the next 2 years, again, regardless of age, she's got a 15% risk of having another fracture. So that fracture, that sentinel event, really does mark that patient as high risk. And then finally, they carried out this study in the Medicare patients for 5 years. And if we look in this pink line here, this is the cumulative incidence of a fracture downstream. And over the 5 years, if a woman presents with a vertebral fracture, she's got over 5 years a 40% chance of having another osteoporotic fracture. If it's a hip fracture, it's about 25% risk over 5 years. So that incident fracture is critically important and does tell us something very important about the imminent risk, if you will, of another fracture. So people have said people with high near-term or imminent fracture risk, they should be as aggressively treated as we can. And perhaps it's even been suggested that perhaps that initial therapy ought to be with an anabolic agent. But whatever it is, you want to take action quickly and get some kind of treatment in place if you're looking at a patient with this kind of risk over time. So fortunately, really over the last 25 years, we've come a long way in this field, and we now have 11 FDA-approved therapies for postmenopausal osteoporosis. And what this slide summarizes are these agents, kind of listed here on your left, and these X's indicate the sort of phase 3 data results that show that fractures are reduced compared to placebo at the spine, and you can see all of these therapies reduce subsequent spine fractures. About half of them are potent enough to reduce the hip fracture downstream, and then a little bit more than half reduce non-vertebral fractures. And all of these are compared to placebo in phase 3 double-blind randomized studies. Now, I know this is an internal medicine audience, and I think the most common agents that internists are comfortable with are the bisphosphonates, which I've highlighted over here. And fortunately, we have 4 that we can use all the time for the treatment of osteoporosis, pretty much. These 4 agents down here that I've bolded and underlined are the ones that typically specialists use, and they're some of the more potent agents and do require perhaps a little bit more experience with some of them to feel comfortable using. But these agents have moved most definitely into the armamentarium of the internist based on the ACP guidelines. And we're going to talk about those next. So in 2023, this very, really excellent guideline was produced by the ACP. They came up, it's very well written and well done. They came up with 6 key recommendations, and we'll look at those in a moment. And the one, I think, very strong point about this guideline is it applies to postmenopausal women, of course, where we have the most data, but they took the data that we did have in men and combined it with the data in postmenopausal women. And now men are included in this guideline, which I think is a real advance. They use the grade system that I think everyone's familiar with to benchmark the evidence that they summarized. And they did a meta-analysis, a network meta-analysis to base this guideline. So very well done and rigorous. And they noted a couple of important trends, and I want to point these out to you. Just what we talked about, a prevalent fracture raises the risk of the next fracture, that imminent risk that we just talked about. They noted that 10 million adults in the United States have osteoporosis. That's clear and common. And then another 40 million, okay, of osteopenia and are at risk for fractures as well. They pointed out that fracture rates in non-whites are increasing, and it's been well publicized, really, that the outcomes in non-Caucasian people with fractures are worse, the survival, the care, and so forth. So they pointed that out because that's become clear. And they also pointed out that men with hip fractures in particular have a greater morbidity and mortality than women. And this is a very significant gap in care if we're not taking care of those patients. So very good evidence to update the guidance. So here are 4 of their recommendations. And the first is to recommend, and you know that that word means that we've got good evidence, strong evidence. So it's a strong recommendation. So the first recommendation is to use bisphosphonates as an initial treatment in postmenopausal women with what they call primary osteoporosis. Recommendation 1B is suggest the use of bisphosphonates for men with osteoporosis. This is lower level evidence, but nonetheless, it's right there in guideline recommendation number 1. And then the next step would be the use of a rank ligand inhibitor, denosumab, as a second-line therapy in women if there are contraindications to bisphosphonates or intolerance. A little bit less moderate certainty evidence, but still a reasonable recommendation. And the same with men. So women and men, the next drug would be denosumab. And then over here in recommendation 3, they suggest, again, because the evidence base is there, it's moderate, but it's not super strong. So they suggest the use of the sclerostin inhibitor, romosozumab, and we'll talk about that in a moment, or teriparatide, PTH 1-34, followed by a bisphosphonate. So they're talking about sequential therapy in the very high risk patient. And then finally, use an individualized approach about whether you're going to initiate drug therapy in women over the age of 65 who just have the low DEXA. So that's sort of low certainty, conditional, but they wanted to get that in there, that it's important to individualize the person's risk. So just a word about the bisphosphonates. I think we have plenty of experience, all of us, with the use of those drugs for the treatment of osteoporosis. They do have, and this has been well analyzed, a favorable balance in terms of risks, harms, efficacy, costs, et cetera. And in general, they align pretty well with patients' values and preferences, which was important in the ACP. So they are our first-line agent. The second-line agent is denosumab. And this drug, and I'll tell you a little bit more about it in a moment if you're less familiar with it, it does share the same risk of osteonecrosis of the jaw and the atypical femur fractures as the bisphosphonates have. So that's important in a discussion with the patient. And when you're making that treatment decision with the patient, all of this should be carefully reviewed. So what is denosumab? This is a busy cartoon here, but it is a neutralizing monoclonal antibody, and it's shown here in this little cartoon by this green symbol. And what it does is it neutralizes, or it blocks the interaction of rank ligand, and that's this pink flower-like thing over here, with its receptor, the purple rank. And this receptor is on every cell in the osteoclast lineage in our bodies, in our bone microenvironment. And so when this monoclonal antibody is present, it blocks that interaction, and all the steps in the formation of the osteoclast and then the osteoclast's ability to resorb the bone are blocked when denosumab is present. And pretty much every hormone, every cytokine, whatever is in our bodies pretty much that stimulates bone resorption works through this pathway. So this is a critical molecular target in sort of the pathogenesis, if you will, of bone loss. So we've got a lot of data, and this goes back over really about a 15-year period. We've got a lot of data on the efficacy of denosumab. It comes from the phase 3 trial, which showed a reduction in vertebral fractures, non-vertebral fractures, hip fractures in postmenopausal women, and that led to the FDA approval. But we also have an extension study which added 7 more years to this phase 3 trial, and so we have 10 years of efficacy and safety data. And in that extension study, and I'll show you the data in a moment, safety was the primary outcome, and bone density and fractures were looked at in these patients. So what you're looking at is that extension study that I just mentioned, and we're looking at bone mineral density. In the upper left is your lumbar spine, to the right is your total hip, below here is the femoral neck, and here's the radius. And the upper curve, that light blue line, are the patients that received denosumab for the full 10 years. So the phase 3 study for 3 years, followed by the extension study. And you can see that at the spine, bone density goes up quite significantly, 22% by the end of 10 years. Patients on placebo, right here in green, then are put on active treatment, and they follow, the curves follow very similar slope of increase. If you look at the total hip, a similar pattern. In the 10 years of treatment with denosumab, about a 9% increase in total hip bone density. And then here are the patients from placebo following the same kind of curve. Femoral neck, similar, about a 9% increase, and about a 3% increase down here on the right in the distal radius bone mineral density. So very steady, very regular, very consistent increases in bone density. It's surprising, the question that people have asked about these data, why does this happen? We have an anti-resorptive. How much bone resorption is really going on over those 10 years? We know that in the beginning, probably it's a pure anti-resorptive effect, but we're not sure why later on bone density continues to go up. Some have said maybe there are increases in PTH that take place. Maybe there are other factors. We're really not sure, but these are the data. Now, we did not have a placebo group in this study over the 10 years of it. So what they did was they did a simulated control group based on the fracture rates that were occurring in the placebo group during the first 3 years. And then they did an estimated relative risk of new vertebral fractures over 10 years and non-vertebral fractures. And you can see the new vertebral fractures were reduced by this kind of a calculation, about 40%, and the non-vertebral fractures almost 50%. So efficacy seemed to be preserved over time. No new serious adverse events or no new regular adverse events of concern developed. They saw one atypical femur fracture in each group, and they saw 7 cases of osteonecrosis of the jaw over 10 years and 6 cases in the placebo group over the 10 years of the study. So efficacy and safety were the big endpoints of this extension study. And the conclusion was risk-benefit looks favorable and efficacy is preserved over time. So very, very important if you're going to be recommending this as a long-term therapy for your patients. So in the meantime, from those initial studies, there have been several other groups of patients at risk for fracture and have osteoporosis where we have approved indications. So it's approved, as you saw the data, for postmenopausal osteoporosis. Based on the data in men at high risk for fracture with osteoporosis, denosumab's approved. It's approved for steroid-induced osteoporosis. It's approved for men on androgen deprivation therapy, with prostate cancer, and it's approved for women on aromatase inhibitor therapy for breast cancer. So there are 5 FDA-approved indications for denosumab at this point. So we see it used fairly commonly in practice. Well, what do we need to think about if we're going to move to denosumab, for example, in treating our patients at high risk for fracture? You do need to have the discussion about osteonecrosis of the jaw. And the numbers I use come from the literature, about 5 cases per 10,000 patient years. Might be something to discuss with your patients. And the atypical femur fractures, this comes from registry studies, maybe about 7 per 10,000 patient years. So it's good to discuss that with our patients. We recommend ongoing dental preventive care, and that's just good medicine in general, but definitely important when patients are on these agents. Now, one very important thing to recall as you're prescribing is that if a patient misses doses of this medication, it's a monoclonal antibody, so it only lasts for 6 months, doesn't attach to the bone like the bisphosphonates do. And once this the half-life and once the compound is out of the body, bone resorption quickly recurs. And patients can have, it's rare, but patients can have rebound, particularly vertebral fractures. So it's very important that patients adhere closely to the treatment schedule every 6 months, plus or minus 2 weeks. And that needs to be discussed at the outset. Importantly, this is an agent that can be given to patients with chronic kidney disease, and you don't have to make dose adjustments. However, you do need to be very careful about patients who have CKD stage 4 and stage 5 because they have a risk of hypocalcemia, and that needs to be carefully dealt with. So those are just some pointers about using or considering to use denosumab in your clinical practice. Now let's turn now to the anabolic agents. We have 3 in clinical care: teriparatide, PTH 1 to 34. It's been in clinical use for the last 20 years, and as you saw, is suggested as a recommendation in the ACP guidelines. We have abaloparatide that was approved about 8 years ago, wasn't included in the ACP guidelines, and we have romosozumab that was approved about 5 years ago. So I'm going to talk to you a little bit about abaloparatide and romosozumab, because I think those data are pretty striking and important for us to know about. So abaloparatide is an analog of the PTH-related peptide, the cancer peptide. Many people think of it that way. So here's PTH. If we just sort of schematically think about PTH 1 to 34 in purple, PTH-related protein, you can see, shares a lot of homology with PTH, but a lot of differences. This compound, abaloparatide, is exactly the same sequence as PTH-related protein up to amino acid 22, and then there's significant divergence in the structure. And this is a designer peptide, if you will. It was set up to sort of capitalize on the anabolic properties of PTH, because we know PTH, Forteo, is used to stimulate new bone formation. But this one was set up to capitalize on that anabolic activity and sort of block or sort of diminish the effects on bone resorption. So it was set up to be a biased agonist to the PTH receptor. Well, how does it actually work in clinical care? So this was the first study in the phase 3 study that compared abaloparatide, and that's going to be shown in the different curves that you're seeing here in orange, and teriparatide with placebo. And it was an 18-month study. And this study met sort of 4 of the top key fracture endpoints in just 18 months. And let's look those over quickly. So for non-vertebral fractures of abaloparatide, you can see reduced sort of the rate of those fractures occurring over those 18 months compared to teriparatide and compared to placebo. It's about a 40% decrease in non-vertebral fractures. When we look at all clinical fractures, again, about a 43% decrease with abaloparatide shown here in orange. And then if we go over here to the major osteoporotic fractures, and these are the ones that when you do the FRAX algorithm, you get the rate, you get the rate of these 4 major fractures. Those were 70% reduced by abaloparatide in 18 months compared to placebo. And then finally, the primary endpoint of this study was the reduction in morphometric vertebral fractures, and that was practically 90% reduction. So clearly met the 4 key fracture endpoints and the primary endpoint in this study. Well, 18 months is a good period of time for treatment, but we need to have follow-up therapy, and all the studies are strongly recommending that. So in this study, patients who were on placebo or who were on abaloparatide, they went on to alendronate for another 2.5 years or so. And so what we're looking at here in the middle are those patients in orange who were on placebo and then went on alendronate. This is the rate of new vertebral fractures, about 3% over that period of time. The patients who received an 18-month course of abaloparatide in black here, followed by alendronate, you can see they had nearly a 90% difference in the rate of new vertebral fractures over that period of time. And then if we look at the whole sort of 3.5 years of treatment in this trial, you've got an 85% relative risk reduction for new vertebral fractures. So that first 18 months of anabolic therapy really carries over to giving a benefit to the patient, even compared to alendronate. And then just following up the other fracture types that were looked at in this extension study. These are time to event analyses of fractures, and you can see these dark curves are the patients that received abaloparatide for 18 months, followed by alendronate for 2.5 years. And you can see that in all cases, there's a risk reduction compared to the placebo followed by alendronate group. So 40% reduction in non-vertebral fractures, 30% for all clinical, and a 50% reduction in major osteoporotic fractures. And you see the curves separate and they stay apart throughout. So there's definitely a benefit of that anabolic, use of that anabolic therapy in these high-risk patients. There's definitely a carryover of those benefits. Well, what about side effects? If you're considering teriparatide according to the ACP guidelines, or you're thinking about abaloparatide, what do you need to think about in terms of adverse events to talk to the patient about? So dizziness, joint pains, back pain, nausea, those are the most common side effects that people experience with this daily injectable therapy. About a 10% rate of elevated urinary calcium. They didn't see significant serious adverse events that were different with these peptides versus placebo. There was a small rate, 3.5% of hypercalcemia in this clinical trial. The costs are less for abaloparatide than teriparatide, but nonetheless, these are expensive medications because they're daily injectables, and they require the daily injection. And so the ACP, as well as other guidelines, recommends either a sequence of teriparatide or abaloparatide, followed by a bisphosphonate to maintain the gains in bone density and to achieve that, increased risk reduction for fractures that we just looked at in that extension study. So let's take a brief look at the other anabolic agent, romosozumab, again mentioned as a suggestion for treatment of women with postmenopausal osteoporosis in your ACP guidelines. So this is also a neutralizing monoclonal antibody, and it neutralizes a protein that is very important in the bone called sclerostin. And I've shown you over here on your far left, sort of where sclerostin is acting. It's acting on the Wnt pathway. And if this is a schematic of what's going on in the bone, when the Wnt pathway, and Wnt is the ligand, and these are its two receptors in the membrane, when the Wnt pathway gets activated, gene transcription, through a series of sort of signaling steps, gene transcription takes place, and bone formation gets stimulated when Wnt is turned on. And bone resorption actually is modestly inhibited. So you have a very powerful effect of this pathway to stimulate new bone formation. Well, there's always, checks and balances in the system, and sclerostin is the natural inhibitor. This little red molecule we've put in here is the natural inhibitor, or the natural brake, if you will, on the Wnt pathway in bone. And so when sclerostin is present, this whole pathway gets interrupted, no bone formation is taking place, and so forth. So that sclerostin shuts down bone formation. But when you put in a neutralizing antibody like romosozumab, it soaks up all the sclerostin, and the Wnt pathway can get activated, and you get an increase in formation, and you get a decrease in resorption. So this is a bifunctional type of compound acting on formation and on bone resorption. 2 trials we'll go quickly through in this agent in postmenopausal women. The first was the FRAME study, and you can see it was a big study. In the first year, it compared the monoclonal antibody romosozumab to placebo, so that's your placebo controlled portion. And then in the second and third year, patients received denosumab that we just reviewed, the anti-resorptive monoclonal antibody. And in this ARCH study, 4,000 women, all of them had a fracture at baseline, so that's the very high-risk group of patients. This was an active comparator study. So in that first year, instead of placebo, they compared romosozumab to alendronate, and then in the next 3 years, all the patients in the study received alendronate. So those are the 2 trials we'll look quickly at. And we'll just look at fracture data. So in that FRAME study, that first one, 7,000 women, if we take a look at the incidence of new vertebral fractures, and that's in this panel A up here on your upper left, you can see that the placebo's in blue here, and the patients receiving romosozumab in the orange, they had a 73% reduction in new vertebral fractures within the first 12 months. So acts very quickly and is very potent. If we carry that over 24 months, and again, at that point, the second year of the study, everyone got active denosumab. You can still see a benefit in the patients that got that 1 year of romosozumab. Here they are over in green. They have a 75% relative risk reduction in new vertebral fractures over the 24 months of the study. So a benefit that carries over. If we take a look down here in the two curves on the bottom, what we're looking at here is a time to event analysis. And romosozumab is shown in red, the little red dotted curve. And you can, and the placebo followed by denosumab is in the blue curve. What you can see is that it takes longer to have a clinical fracture, the red curve, when you've received romosozumab versus the placebo followed by denosumab. And similarly over here, panel C, the time to a first non-vertebral fracture, the curves separate and they stay separated in the red line in patients who've received romosozumab. So that 12 months of anabolic therapy definitely has an impact that carries over. Now, this study, as I told you, went on for 3 years. And what we're looking at here are all clinical fractures in panel B, and we're looking at non-vertebral fractures in panel C. And the patients receiving romosozumab, it's shown in gray in both of these curves. And you can see that there continues to be, even out here after 3 years, there continues to be a separation, 30% reduction, if you will, in these patients who received that 12 months of anabolic therapy with romosozumab for all clinical fractures. If we look over here for the non-vertebral fractures, the curves remain separated out here at 36 months, and it's about a 20% relative risk reduction compared to the placebo followed by 2 years of denosumab. So you are getting long-term benefits from having that year of anabolic therapy. This is that second important trial on the use of this agent, and that's the ARCH trial. This was the head-to-head comparison of romosozumab versus alendronate. And let's take a look at how that stacks up. So we are looking now at 2 active arms of treatment. So patients on romosozumab, they're in the gray bar here compared to alendronate. And what we're looking at in the first 12 months is the incidence of new vertebral fractures, almost 40% lower in patients on romosozumab versus active treatment with alendronate. If we go out to 24 months, it's almost a 50% relative risk reduction for new vertebral fractures. So it's clearly more potent at that endpoint. Again, the time to event analysis for the first clinical fracture, we're looking at that down here in panel B. And you can see the curves separate out here by 12 months and they stay separated. And this is a statistically significant separation. And it takes longer to have a clinical fracture if you have received a course of romosozumab, and the same with non-vertebral fractures. The curves stay separated. Now, importantly, I don't have a figure of this, but importantly, they also looked at the rate of hip fractures. And those patients who received that 1 year of romosozumab versus the alendronate had a 40% reduction in the rate of having a new hip fracture. So highly significant, along with all of these other fracture endpoints. So basically, the critical endpoints for superiority were met by romosozumab, comparing it to alendronate. So head-to-head, it outperforms alendronate. When you look across both of these trials, the adverse events and serious adverse events, looking at everything, were balanced. Injection site reactions are definitely something because this is 2 injections with each dose, which is given every month for 12 months, about 5%. And in that second study, the ARCH study, these were the older women, the higher risk women. They did see an imbalance in the number of cardiovascular serious adverse events, about 30% increase in those. Cardiac ischemic events were about 2.5 the odds ratio of that was about 2.5-fold increased. There were, in other words, 16 cardiac ischemic events in patients who got Romo versus 6 in the alendronate group. And there were similarly 16 cerebrovascular events versus in the Romo group versus 7 in the alendronate group, and you can see the deaths. We don't have a biological mechanism for any kind of accelerated cardiovascular adverse events in these patients, but the FDA looked very, very carefully at these data, and they decided that they would, approve this medication for patients at high risk for fracture with osteoporosis, but put a black box warning on it to avoid it if patients had a recent MI, a recent stroke, or isn't otherwise high risk, because they don't have an explanation at this point in time, and our job is to do no harm, of course. So the ACP, coming back to the ACP guidelines, they tell us to consider teriparatide or Romo in the very high risk osteoporosis patients. So that's where we are with the use of this compound in clinical care. So in my last few minutes, I'd like to talk briefly about some of the new data and new ideas with respect to vitamin D and skeletal health. Well, if any of you follow this area at all, you know that it's really quite controversial, and it's difficult to even come up with a consensus on what the definition of vitamin D deficiency is and what vitamin D sufficiency is. So it's a controversial area, and I take a risk even stepping into it, but I do think it's important because we get so many questions about it. And one of the questions that really comes up with what levels of vitamin D, or 25-hydroxy vitamin D, and that's the compound we're talking about here, should we be targeting different levels of vitamin D in the healthy population versus patients who are at risk for fractures or have fractures or osteoporosis? And then a very important trial came out called the VITAL trial, and we'll talk about that in a moment. But the question really is, how much does this help us in telling us about how we should care for patients with osteoporosis? And then finally, a couple months ago, a new set of guidelines on vitamin D for disease prevention came out, and it's important to think to just review that, some of that very briefly with you. So the VITAL trial tested vitamin D and omega-3 fatty acids and looked at whether supplementing with vitamin D 2,000 units per day or the omega-3 gram per day could either prevent cancer or reduce cardiovascular disease. And so it's a well-done study, very large study, as you'll see in a moment. There were 4 treatment groups here, and men over the age of 50 and women over 55 were enrolled. Now, the skeletal health sort of sub-study of this looked at quite a few things, but we'll look at the fracture data, which is the most recent. And they looked at all fractures, they looked at non-vertebral fractures, and they looked at hip fractures. So that's the skeletal part of the VITAL trial. Almost 26,000 patients were in it, 50% were women. You can see the age, late 60s, and reasonably balanced in terms of ethnic diversity to reflect the US population. At baseline, about 10% had a history of fractures. The other important things at baseline in this population, and this is going to be important for thinking about what we're learning from the VITAL trial, is that 43% of the patients enrolled in this study were taking vitamin D at baseline, and that was allowed as part of the study. And the baseline vitamin D 25-hydroxy levels were 31 so this was a population of people on average who were highly vitamin D sufficient. No one would argue that. And then during the trial, the 25-hydroxy levels went from 29, and this is just the only difference here is this was the population where they had follow-up measurements, to 41. So on average, these people were sufficient at baseline and increased. And the follow-up was 5 years. So long enough, a large enough study to gather fracture data. So here are the fracture outcomes. And this was the primary endpoint. Total fractures, no effect of vitamin D versus placebo on the hazard ratio of fractures if we look at all fractures. If we look at just non-vertebral fractures, then you can see the number of fractures that occurred, several hundred. So we have reasonable power in this study, if you will. No difference in non-vertebral fractures. And then if we look at hip fractures, there weren't a lot of them, but you can see that the numbers are basically superimposable, so no effect. And then they did various subgroups and looked at all these different subgroups and really did not come up with a single fracture subtype that was statistically significantly affected by taking vitamin D versus placebo. And if they looked at whether age, gender, race, ethnicity, BMI, use of supplements, you name it, all kinds of possible other interacting factors, none of them affected the fracture outcomes. So what do we take home from this? And I think many patients have, come to us with questions about vitamin D. I think we can say that vitamin D by itself doesn't lower the risk of fractures in patients not selected on the basis of vitamin D deficiency. Okay, so in a sufficient population, you don't get any benefit on fractures of giving more vitamin D. And this is, I think we can say this is the case for men over 50 and women over 55. 40% of them were supplemented at baseline and were sufficient on average at baseline. So we can't add on to the benefit, so to speak, if there is any, of vitamin D. But I have to say that many times when this comes up, I really strongly wonder whether these data apply to the patients I'm seeing in the bone clinic or who are coming into the hospital to get their hip fracture and other fractures treated. I don't think this is the same population at all. And so honestly, I haven't changed my approach to vitamin D supplementation of patients at high risk for fracture. But we can discuss it later. So this final study that I'm going to tell you about are some guidelines that were produced by the Endocrine Society on vitamin D for the prevention of disease. So why are 40% or 43% of Americans in the VITAL trial taking vitamin D? Because people believe that it might help them in terms of other disease preventions as well. So this particular guideline was an effort to kind of look at all of those data. Hundreds and hundreds of papers were reviewed for all the other benefits, quote unquote, that vitamin D is supposed to produce. And I've listed some of them here. So what they did in this guideline was to look at 14 different areas of across the lifespan of where vitamin D might be used to reduce common disease. So this is completely different from looking at whether vitamin D has a role in osteoporosis. Okay, this is very different. And for this guideline, they defined what they call empiric supplementation as giving more vitamin D than what the Institute of Medicine recommended, sort of the dietary reference intakes from the Institute of Medicine report, and not using 25-hydroxy D measurements to guide it. So empiric supplement is just taking a supplement without really supervision or really without using levels to measure it. And as I've said, this guideline does not address what to do in bone disease or patients with fractures. And we'll look at just a couple of the recommendations that might be important to an audience of internists. So recommendations 2 to 5 basically boil down to the fact that adults less than the age of 75, this guideline suggests, because the data are not strong enough, that you do not need to do vitamin D supplementation and you do not need to do vitamin D measurements. And you can see it's level 2 evidence and there's not a heck of a lot of it, but they're suggesting against it. In recommendation 6, in the general population, 75 and over, they are suggesting that empiric vitamin D supplements be given because there's the potential to lower the risk of mortality. Level 2 evidence, a fair amount of it, okay? And they made a few comments. Daily dosing is preferred over high dose, given once every year or once every month. And they did not put out a strong view about how much. The studies are heterogeneous in terms of the amounts. So they said 800 international units per day is reasonable. So this does apply to a lot of the patients that we see in clinical practice, if you want to do that. And then recommendation 7 was a suggestion against screening. So we shouldn't be getting vitamin D levels to screen patients unless they meet the criteria for screening. For example, they have a low blood calcium or fractures or something like that, but just not to screen the general population. Recommendation 10, now this is important, particularly for me as an endocrinologist, for adults with high-risk prediabetes who meet 2 out of the 3 ADA criteria for prediabetes, and I've listed those here. In addition to lifestyle, to slow the progression to diabetes, they suggest empiric vitamin D supplementation. And that I think is important, and that one I've taken to heart, and I'm considering doing that in patients. Recommendation 12 was their suggest against routine screening. I've really already mentioned that in people who are healthy. They've suggested against routine screening of patients with dark complexions, just because of that, property alone. And then for patients with obesity, again, they also suggest against routine vitamin D screening. And the reasons for some of these, is that if we screen and we get a level, we actually don't know what level to try to reach with supplementation to get a benefit. They haven't been established in clinical trials, and that's the reason for that. Again, I don't know that this necessarily means I shouldn't be checking this, and I'm not going to necessarily change all my practice, but these are the guidelines that are out there. And this is just what I've said. We don't have the optimal levels to achieve to get a certain health outcome, so they're saying no need to make the measurement. And these different clinical scenarios, and there are several others, I just pulled out a few of them. They recommend the supplementation only in a couple of them because there's a possible benefit. The cost of the intervention, vitamin D tablets is minimal. And particularly, there's a good cost-benefit ratio if you're not making a lot of repeated 25-hydroxy-D measurements. So they say the benefits will outweigh the low risk of this kind of an intervention. So that document, I think, is pretty important because of its, sort of unbiased, I think, summary of the literature. So let's quickly conclude. We've looked first at osteoporosis, how we make treatment decisions, and how important sort of baseline risk and imminent risk are in making those treatment decisions. We spent quite a bit of time on the ACP guidelines and what they recommend as first line for both women and men, which are the bisphosphonates, denosumab as the second line, and then consideration of the use of either of the anabolic agents, teriparatide or romosozumab. And we talked about efficacy and side effects. We reviewed the VITAL trial and we reviewed the most recent vitamin D guidelines for disease prevention. But I want to underscore to you, and I think I have as we've talked about it, that neither really of these important studies and documents are directly relevant to the management of osteoporosis. But they do give us general guidance for vitamin D supplementation, for screening, and I think some very useful recommendations for kind of management of general health in older patients. So with that, I will conclude. Thank you very much again for the invitation to come and for your attention, and like to be happy to take on any questions that I might answer.
Well, thank you so much, Dr. Shoback, and turn it over to Dr. Moshe Gundam, but I will ask one question as chair. Having had patients with bronch, the osteonecrosis of the jaw is from bisphosphonates, it's just horrific to go through as a patient, and you feel helpless to help them. Is there any hope on the horizon of selectively inhibiting the bone overgrowth in that area? Is there? I know it's not as common, and maybe it's not getting the attention, but I'm hoping that there is some way of trying to make that better.
Yeah, very, very important. And this is obviously something that patients worry a great deal about. They all come prepared to talk about it and say why they're not going to take any of these therapies because of that. I really stress, preventive dental care. Try to get anything that needs to get done before we initiate any of these therapies, and work very closely with our oral surgeons and dental providers. There's quite a bit of data, or some data, I should say, in animal studies, animal models of alveolar bone, disease and bone loss in models where teriparatide, for example, has been used to help, enhance the healing of the osteonecrosis of the jaw. And so that is something that we sometimes will do. We'll use an anabolic, particularly the teriparatide or the abaloparatide, to try to help with that. And then limiting the course of some of these therapies And we didn't really talk about it, but, sort of the initial course of therapy with the bisphosphonates can be 3 to 5 years. And so we don't do the sort of endless therapies that were much more associated with ONJ. But yes, you're right. You still do see it, and it is very difficult and really hard on the patient. I think that's all I'll say about it, but I share your, concern about it for sure.
Oh, thank you. Dr. Mashagunjan?
Thank you very much, Dr. Shoback. Certainly, I think we are all familiar with the use of the bisphosphonates and somewhat with denosumab. The newer ones, the romosozumab, and of course the parathyroid hormone is less frequently used, especially by internists. One of the things that I noted in those studies was, at 4 years, the number of people who are followed, had it dropped dramatically in that way?
Oh, okay. So thanks for that question. And what a good observer. My gosh, I was looking at that last night myself, and I was, because you want to know exactly how long do we actually have the data for, right? Mm-hmm. So those were event driven. So some of the people got out to 4 years, but it was not a 4-year study that everyone had to meet the 4. This is a very, wow, you really looked at the data. So at any rate, they did not all have to get to 48 months, for example, in order to have the study be properly conducted. Once they got a certain number, as I understand it, I wasn't one of the sites, but as I understand it, as they got the number of events that would trigger, the significance that they were looking for and to prove superiority, et cetera, they then, the study was gradually, I guess, stopped, because they met their endpoints. So so some people, I guess the ones that were the earliest starters got out to 4 years, but the rest didn't have to go because they proved the efficacy.
Okay. Because one of the things that has been mentioned by some others is that alendronate actually has some cardiovascular benefits. And because there was no comparator, which was placebo. And so the cardiovascular event data was not as strong as we think it should have been. So I don't know, is there a study going on looking at with, placebo control or,
I don't think the appetite for placebo-controlled studies, particularly doing one where you're going to look for a rare major adverse cardiovascular event, a MACE, there's not an appetite for it because you'd have to really carefully stratify people and try to get sort of the highest risk patients into a study like that, and I don't think they'd be volunteering. But you do bring up an interesting point, and there has been a deep analysis of that first 12 months. And just what you said, which is that when they took sort of historical controls, the rate in women who were average age, I guess 74 when they went into the study or something, the average rate of cardiovascular events was lower in the alendronate group. So it was kind of, you were comparing romosozumab to an agent that for whatever reason or fluke or, type whatever error, actually had a sort of some cardiovascular protection in that first 12 months. And I've talked to quite a few cardiologists about this, ones that do trials, and they, the number of events are so small. They said, that's probably not a signal. That's probably not a signal. But it's reported. And I think the FDA, I read the FDA report. I mean, they really carefully adjudicated all of these events. And, I think the black box warning is their effort to say, look, we don't have a mechanism, but we're telling you what the data show. And you, as a clinician, decide whether this is an agent that you feel is safe enough for your patient. And I think that's all they can do at this point.
Thank you. There are a few questions on the chat.
Yeah, just real quick, Doctor. I think Dr. Furman had a question as well. Dr. Furman, are you still with us?
Sorry, yes. I was just wondering, I'm a geriatrician, so we see a lot of the hip fractures, and there's always a trick of when, like, they're already on like a bisphosphonate and they have a hip fracture. What is your recommendation about treatment around the hip fracture?
Yeah. You're right. It does come up. We don't prevent all fractures. We don't prevent all hip fractures either with any of our therapies, because you as a geriatrician know how many other things play into what leads to a hip fracture in a frail older person. in general, if it's a hip fracture, I'm usually going to change therapy. I mean, unless they've just recently started and the drugs didn't have really a chance to have a full effect. But in general, I'm thinking, let me try something else. Sort of internationally, the consensus is that, you need 2 fractures in order to say that a treatment has failed. But I think a hip fracture is a big enough event that I'd actually want to use something stronger than I'm assuming you mean an oral bisphosphonate. But
Yeah, right. Like they're on
Yeah.
Fosamax or something. Yeah.
I mean, because, how do we measure efficacy? If you do a DEXA 2 years later and you find out at that point, maybe they haven't been absorbing it well or haven't been taking it. I think it's time to move on to something that's a little bit stronger.
Thank you. Thank you so much.
Yeah.
Dr. Mokshigundam, do you want to touch on the questions in the chat, or I can do it? I think you're muted, Dr. Mokshigundam. No. Well, one of the questions we had is from our Dr. Halsam Sarakbi, who is actually our new chief of rheumatology here. And one of his questions is, what are our options for CKD class 3 or higher or in dialysis patients? He said, you mentioned Densumab. Are there any other options?
Yeah. Well, tough question, comes up in clinic every week practically. Because those are the hardest patients. When we don't have, a bone biopsy, which is almost 100% of the time, you really don't know what you're treating, right? And so that becomes a question as well. Some of us you can use denosumab. You have to be very careful in CKD 4 and 5 and the dialysis patients because of the risk of hypocalcemia. And there was a JAMA article that just came out this year highlighting that risk, and that led to a warning or a labeling change, warning physicians about the use of denosumab in that patient population and the risk of hypocalcemia. There were even some deaths in that sort of survey of patients that received it. So what can we do? We can use it, but we have to be very careful to check calcium, give calcium supplements, and check serum calcium levels. When I do it, I check it every week, and it's for at least like 6 weeks. If they're getting dialysis, in general, the dialysis, physicians are working with me on it, and they're checking those labs because they come so frequently. So it works okay in the dialysis patients. The ones that aren't on dialysis, you have to basically do that. So it does become a lot of monitoring for those patients. So you can use denosumab in that group. Sometimes it's completely off-label. Sometimes we use oral bisphosphonates. Sometimes we use residronate or alendronate in half dose, depending on the degree of renal insufficiency that the patients have. But in the dialysis population, our pharmacy doesn't get excited about our use of oral bisphosphonates at all in that population. So sometimes with reduced renal function, you can use it every other week or the half dose. So those are some of the options. The use of teriparatide, the use of abaloparatide, often the PTH levels are high already in these patients. So it doesn't make sense to use them, and there's very little data. But that would be what I would use. And romosozumab has been looked at in CKD3. There were some CKD3 patients in those trials, and it seems to have the same effect on bone density and fractures as sort of normal renal function. So those would be your options, but you'd have to be careful with the romosozumab because of the cardiovascular risks, and that's a high risk population. So it's tricky.
All right, we have a question from Dr. Levinson, one of our endocrinology researchers. He said, thank you, a very clear and helpful talk. He said, are there comparisons of the antibodies and the synthetic hormones?
Oh, head-to-head comparisons of all of that. Not as many as you would like to see. For example, the romosozumab followed by denosumab, that's the kind of comparison that you have, but it's not a direct head-to-head denosumab versus versus Romo in that same population, sort of compared that year kind of head to head. It's what you've seen, the sequence. And then comparisons of, for example, teriparatide and romosozumab was done in one study, and it was a study called Structure, where they took a group of women that had received at least 5 years of typically bisphosphonates, and then either gave them teriparatide, half of them went to teriparatide, and the other half went to romosozumab. And they showed in that study, it's a very nice study, they actually showed that romosozumab outperformed teriparatide on bone density, and also on, they did QCT, and they looked at hip bone strength. It's a non-invasive measure of strength. It didn't have fractures. And when they looked at hip bone strength, it was actually improved compared to, with Romo, compared to teriparatide. Those are, thinking quickly, those are the main sort of head-to-head type of studies and what I showed you. But doesn't happen very often that we get that kind of a comparison.
Another question is from Dr. Robert Emmons. He's actually in our hematology oncology and actually in our BMT group. He said, can you comment on the contribution of exercise and hormonal manipulation for bone preservation? Is there data for this? Core strength especially. What about the contribution of declining immunity?
Oh my gosh, there's several questions in there. Let's try to take one or two at a time. And I'm no expert on exercise. And it really, as I read the exercise literature, you can see modest effects on bone mineral density with exercise. Resistance, it's not just walking and it's not swimming. It's got to be sort of impact exercise. And the more impact, the better the bone density changes are. And they're not big. They're a couple percent on a great day. They're a couple, after a year, 2 years of a program, you're getting a small increase in hip or spine, wherever you're looking. Nothing compared to what happens with the most, anabolic agents. And people haven't looked. It'd be interesting to do that, putting in an exercise program and an anabolic agent and seeing whether you can actually gain more by doing that kind of combination. I'd love to see those data. So you get some benefit from exercise. I think exercise, not only in terms of bone mineral density, that's not all we care about with exercise. What we care about with exercise is the ability to reduce falls, which are the things that lead to the fractures, improve mobility, and improve coordination and sort of prevention of falls and loss of mobility are things that we're trying to prevent, particularly in the patients at the other end of the spectrum, in the oldest patients who get fractures. They're often frail and they're not moving around much and they're falling a lot. So that's, I think, one of the great benefits of exercise. And there, you really want that neuromuscular and balance control that exercise helps with. Your question about, your third question, I think, was about immunity. And honestly, in the bone microenvironment where all this kind of bone resorption and bone formation is happening, I'm sure there's an immune component to it, but I'm not expert enough to really speak about that. But certainly it's all happening in the environment where there are a lot of immune cells and high levels of inflammation and, diseases of the immune system, inflammatory diseases, rheumatologic conditions, all of those are associated because of the high inflammatory markers with ongoing bone loss, rheumatoid arthritis being sort of the poster child for that sort of thing and other inflammatory conditions.
Quick question from, go ahead, Dr. Marshall.
Well, I know we're kind of running out of time, so there's one last question about transgender female patients and about the, how do trans patients fall into the most recent guidelines? That is a question from Dr. Erin Murphy, who's our internist. And
yeah, so so how do we look at bone density in trans patients? I think that's a tough question, and I'm no expert to answer that. Although there is great interest in sort of developing a framework to kind of look at that. if I am, and we do a lot of transgender endocrinology in our clinic, if I am starting a patient on transgender hormone therapy, I'm going to get, and they're in the old side, let's say age 50. Let's just pick an age. If it's someone who's 25 years old, it's a totally different situation. But if I'm looking at someone who's an older adult or middle-aged adult, I'm going to get a bone density at the time I'm doing that. I know that there could be, and the older the person is, I would be getting the bone density and looking at bone health. If you're going to assign a genetic male to estrogen therapy at any point in time, it's useful to have where they start out. So that's one thing that we do. Now, deciding which sort of normative data to use becomes tricky. I look at how many years they've been on the transgender hormone therapy, and I have to say I don't have an algorithm to give you, but I will find one because if this question will definitely be coming up a lot more as we transition more patients and patients who are in older age groups where the risk of fracture is higher, becomes higher. But a lot of your structure, depending on the age of the patient, a lot of the structure is laid down for bone structure is laid down, in the first 2 decades of life. And so the age plays a big role in it, and other comorbidities. Are they using steroids? Are they, other habits, smoking, alcohol, all of those things? You have to do a full assessment of the patient and then look at the BMD with respect to where they would be based on male gender, and then where they would be probably fine if they continue estrogen therapy and go forward if they're not in any trouble. But it's a tough question.
All right. Well, I think that probably kind of gets us to an end point here. And Dr. Shoback, you would know this because actually you're part of this tradition. But we have a tradition for our speakers that they get a nice little gift that's synonymous with Louisville. So you're going to get another bat.
Oh, how fabulous. Look at that.
So to go along with your one from the Towery lecture from 2015. So we'll get that to you. And we really appreciate it. Dr. Mokshagunam, anything you'd like to close with, or Dr. Williams?
I just want to say thank you, and looking forward to the Cardinal Minute.
Thank you.
Yes.
Thank you very much.
All right. Thank you, everyone. And we will see everyone next week. And it'll be cardiology. So it'll be Dr. Atreya from cardiology. So, all right. Thanks, everyone. We'll talk to you soon.